disease overview on septic shock by Nina Herceg, Maria Herrera, and Pritam Steiner. We'll begin by looking at what septic shock is and how it differs from sepsis. We'll take a look at the epidemiology, some very concerning statistics, and highlight specific populations that have the greatest risk of developing septic shock. We'll then segue into the pathophysiology, reviewing hallmark signs and the many detrimental systemic effects septic shock can have on the body. We'll take a look at the manifestations, both generally and then in depth as we follow along with the stages of septic shock. We'll conclude by detailing the management, including pharmacological treatments, specialty referrals, patient education, and preventative care approaches. So what exactly is septic shock? It's firstly a form of distributive shock that results from a severe systemic response to bacteremia or infection and causes life-threatening hypotension. Simply put, the state of circulatory damage is unique in septic shock. There are two main characteristics that differentiate septic shock from sepsis. These are persistent hypotension despite fluid resuscitation, also known as refractory shock, and tissue hypoperfusion, shown by increased lactate levels, which ultimately leads to necrosis, tissue death, and in the worst case, multiple organ dysfunction syndrome. Now, as you can see by this chart, septic shock is not a simple phenomena at all. It is quite intricate and comprehensive, triggered by a multitude of ailments or types of infection, causing a cascade of effects on multiple body systems simultaneously. Because of the severity of septic shock, it is essential to understand who is at most risk and how we as healthcare providers can reduce the incidence of septic shock within our healthcare settings. Septic shock does not discriminate. It is highly deadly and highly costly. It is the leading cause of death in non-coronary ICUs and the 10th leading cause of death in the United States. The CDC's National Center for Health Statistics estimates that the number of times people were hospitalized for septic shock increased from 621,000 in the year 2000 to over 1 million in the year 2008. The incidence of sepsis has increased threefold between 1979 and 2000. More than 70% of these patients have underlying comorbidities, and more than 60% of these cases occur in those aged 65 years and older. Between 28 and 50% of people who get sepsis die, percentages that starkly highlight the dangers of septic shock. The annual incidence of sepsis is increasing by 8%, and as mentioned, is greatest in older adults. As you can see by this chart, as one's age increases, so do the incidence and fatality rates of septic shock. Even though septic shock can affect anyone, the young, old, pregnant, and immunocompromised are at higher risks. Not only are people's lives put at risk with septic shock, the costs of treating this life-threatening condition is rapidly increasing. In the United States alone, it is estimated that approximately $15 billion is spent on severe sepsis every year, and of course half of these costs are spent on treating those 65 years and older. The rise in the number of cases of septic shock is believed to be caused by various factors, such as an increase in the aging population, a rise in chronic diseases, increasing use of invasive procedures as well as indwelling lines and devices, increasing transplantation of organs and the use of immunosuppressants, increased use of chemotherapy, as well as rising rates of antimicrobial resistance. The chances of surviving septic shock depend on the cause of infection, how fast treatment is initiated, and the number of organs that have been affected, which is why the pathophysiology of shock will help guide our understanding of what occurs within the body and how to treat and manage this detrimental condition before further damage can occur. During septic shock, the normal physiological response to localized infection occurs on a systemic scale. This leads to endothelial disruption, vascular permeability, vasodilation, and thrombosis of end organ capillaries. The pathophysiology of septic shock involves a complex interaction between the pathogen and the person's immune system. This immunologic reaction is characterized by a hyperdynamic state in which there is an increased cardiac output and decreased peripheral resistance. The outer membrane of gram-negative organisms, gram-positive organisms, as well as fungal, viral, and parasitic components can trigger the pathophysiology of sepsis. This is an atypical inflammatory reaction which leads to an imbalance between pro-inflammatory and anti-inflammatory responses. In the activation of innate immunity, several cytokines are induced, including tumor necrosis factor and interleukins. However, in septic shock, a further release of tumor necrosis factor, interleukin-1, interleukin-8, and interferon gamma occurs due to the presence of bacterial toxins in the bloodstream. Interleukin-8 is synthesized and released in significant amounts during sepsis and contributes to the lung injury and dysfunction of other organs. Other cytokines involved in sepsis include interleukin-10, interleukin-12, macrophage migration inhibition factor, and granulocyte colony stimulating factors. The inflammatory mediators provoke direct injury to the vascular endothelium. The endothelial cells release tissue factor, which initiate the extrinsic coagulation cascade and accelerate thrombin production. Pro-inflammatory cytokines also disrupt the body's naturally occurring modulators of coagulation and inflammation. A dysregulation of this homeostatic mechanism can result in lethal, disseminated intravascular coagulopathy. Neutrophilic endothelial interaction leads to further endothelial injury by releasing of the neutrophil components. Activated neutrophils release nitric oxide, which is a powerful vasodilator and plays a major role in the hemodynamic alterations of septic shock. The endothelial dysfunction and the vascular misdistribution lead to systemic hypoxia in vital tissues. This imbalance between inflammation, coagulation, and fibrinolysis leads to widespread coagulopathy, vasodilation, and microvascular thrombosis, causing multiple organ dysfunction and death. As portrayed by this chart, it is clear that as the pathophysiological characteristics of infection progress from a localized inflammatory response to a systemic reaction and ultimately to severe sepsis and septic shock, the chances of survival are drastically lowered. In review, infection, sepsis, SIRS, and severe sepsis are closely entangled with one another. However, septic shock presents with refractory hypotension and profound vasodilation. These two symptoms are the primary factors behind the many manifestations of septic shock, which will be discussed next. Some general manifestations of septic shock include cool, pale arms and legs, either a very high or low temperature and chills, lightheadedness, little to no urinary output, hypotension, especially orthostatic, palpitations, a rapid heart rate. The patient may be restless, agitated, lethargic, and confused. They may experience shortness of breath and also may have skin rashes or other skin discoloration. The symptoms of sepsis are nonspecific and can often be seen with many other conditions. This is why septic shock can be so lethal. However, when you look at the stages of septic shock, you can see patterns and begin to understand how to recognize a patient who is deteriorating. In early compensated shock, some patients will be tachycardic or have a heart rate greater than 100. They may have warm and flushed extremities, but the blood pressure remains within normal limits as the heart is trying to compensate. As the shock progresses, the diastolic blood pressure will begin to drop, the pulse pressure will widen, and the patient will have bounding peripheral pulses. Temperature may or may not be elevated, the patient will become agitated and or confused, the respiratory rate will increase, and peripheral edema will be present. In late uncompensated septic shock, widespread organ dysfunction is apparent. Upon assessment, patients will be hypotensive as their systolic blood pressure will fall below 90. They'll develop cardiac dysrhythmias, respirations become even more rapid and also labored. Upon auscultation, you may hear rales and the patient may have pink frothy sputum. The extremities will be cold to touch, and there'll be a marked decrease in urinary output, as well as abdominal distension, absent bowel sounds, and the patient may also bleed from invasive lines and have petechiae, and that is due to the DIC, or the disseminated intravascular coagulopathy that we discussed earlier. Now, as the shock progresses, the patient will experience many changes and deteriorate, and they will need support. So as important as it is to make extensive clinical and physical assessments, it's also important to provide support and a comforting environment to the patient and their family during this very difficult time.